Thank you all for joining us. Thanks to those who are joining us virtually. We have folks doing that as well, and thanks to everybody in the room, and a special thanks to our guest, who I personally know how busy a director of NIH is. So thank you so much for joining us this morning, Dr. Bhattacharya. I think most people know about your background. I'll say just a few things. The 18th director of the National Institutes of Health, became that on April the 1st of this year, and a Stanford graduate who I think BA, MA, PhD, and MD from Stanford in terms of a wide range of degrees, and focused on issues from medicine to issues of public health, to research, to economics and health economics. So a very wide range, over 170 published papers, has spent time at everywhere from RAND to the National Bureau of Economic Research in terms of the economics part of this, as well as at Stanford. All of that before becoming the NIH director, and has spent time on population aging, issues of chronic disease, as well as with a focus on vulnerable populations. So a lot and a very broad range, great for the NIH to have someone. Many of you all probably know about the Great Barrington Declaration, and that's where a lot of folks, I think, learned about you and your work. And we'll talk a little bit about that today in our session. Born in Kolkata, India, and with that, welcome so much. We're so glad to have you.
Thank you for having me, Sylvia, and thank you for this opportunity to talk to everybody.
I thought we would actually start with things that people generally, you can't find on Wikipedia or anywhere else, and that's, how did you come to science and economics? How did you come to these topics, and a little bit about your journey, because I think that's always informative to understanding how you lead and how you think about the issues.
I mean, I've loved math and science since I was little. I kind of always wanted to be a doctor, because I figured this is how you use math and science to I mean, it just really sounds cliche, but it's how you use math and science to help people. But I got to undergraduate, and I took, because they forced you to take general ed requirements, that I took an econ class. And I was amazed by the idea that I mean, as soon as I encountered it, I realized the idea of this constraints, like you have to have rigor in your statistical thinking, all of that is really, really important for medicine. It's probably even more important for medicine than it is for economics. And I met a man named Alan Garber, who's the president of Harvard, when I was 19. And he had an MD and a PhD in economics. He absolutely inspired me. And I did an honors thesis with him. I did a PhD in economics. Actually, first I got to medical school, and I realized I couldn't just do medicine. I missed economics too much. So I did a PhD also, and then I had to figure out what I needed to do when I grew up finally. So.
Well, one other question on this kind of history. Lifetime returns to specialization in medicine. That would be the title of Dr. Bhattacharya's dissertation. So we're going to go back in time.
You're going back.
I'm going back.
Ancient times,
I'm going back. I did my research.
Yeah, I can tell, Sylvia.
That is who I am. I, like you, like research as well as other things. Tell us just a little bit about that dissertation.
So the question was, why do surgeons earn so much money? And the basic framework was that you have a few explanations that make market sense, right? So like surgeons have to train a long time in order to get to where they are. So like, no one's going to do it unless they make more money than you would expect. They work a lot of hours. Back then, just before the 80-hour work week for residents, they were like 120 hours. There's 168 hours in a week, you guys. So it's, that's something, right? And so like those would be normal market explanations. Also, you might think that surgeons are like, well, if you ask surgeons, they say they're smarter than everybody else. But so maybe that's why. The dissertation asked, do those market explanations, are they sufficient to answer why they earn so much more money than internal medicine doctors? And the answer is no. About half of what the difference between internal medicine doctors, the sort of the rate of return for internal medicine doctors, lifetime returns for internal medicine doctors versus surgeons, can be explained by these market forces, and the rest is essentially market power, which is actually bad news for the American healthcare system. It means we spend a lot of money, probably a lot more money than if we just had a sort of a more competitive market for surgeons and for doctors just generally.
Boy, we could go a lot of different places, and we will come to affordability in healthcare a little later on in our conversation. It would be interesting if you did this work with nurses. You don't have the length of the education, but some of that I'd be interested.
That is a really interesting topic, and that's
would be a fascinating
that's something I
topic
want to start supporting research on at the NIH, because I think that is fundamental. Both the market for physicians and market for nurses are fundamentally important for the affordability
care physicians and nurses
access
and people
to care.
at top of license. We're going to come to affordability. As you can see, we probably could go deep in a lot of topics, but we want to cover a lot of ground. And one of the places to start, which I think so many people here are probably interested in, and I know is a focus of yours, is biomedical innovation. And I thought we could start the conversation on biomedical innovation on, everybody says we can probably survey this entire room and everybody's going to be for biomedical innovation. But I think the real question is, how do we define success in biomedical innovation? So we get on the right path in terms of, okay, if this is how you define success, how do you think you best get there? So I want to start with, like, you're head of NIH. We are successful in biomedical innovation, and everybody in this room knows it 5 years from now. Please fill in the sentence so we'll all know, did we get there or not?
Well, I mean, that's a great question. And in fact, that's the question I asked myself when I got tapped for this crazy job. The U.S.
And I can confirm it is a crazy job.
It is an insane job.
I just want to confirm.
I really miss being a professor. That was a really fun job. But whatever. This is important, right? So the U.S. has seen no increase in life expectancy in this for people in the country since 2010. From 2010 to 2019, it's flatted like 81 years. And this is true for every single, especially for minority populations, flat. For whites, flat. For rich, poor, flat. Now, of course, there's big differences in life expectancy based on these factors, but the trend is flat for almost everybody. And of course, the pandemic, there was a collapse in life expectancy more than our peer nations. And it's only this year we're back to 2019 levels, which means 2010 levels. If you look at our peer nations, their life expectancies continue to go up. The mission of the NIH is to support research that advances the health and longevity of the American people, of humans. I will not view myself as a success unless we can turn the investments that we make in biomedicine into better health for Americans. That's the fundamental. If you want to understand the moment why we're here, why there's so much distrust in science and medicine and public health, there's a lot to do with COVID, but that fact, why does MAHA exist? Why is it such a potent political force? It's because of that fact. No translation from the real advances in fundamental biological knowledge to better health for Americans.
So as we get to those, like, get into measures, I like measures and numbers and things like that. I want to ask you to create an index between longevity and wellness. In other words, so if, is longevity exactly the right, how do we think about balancing those things? Yeah. If you live a long, long time, but your quality of life is not such, or if you live a long time, but like at 40, you have heart disease and other things. So how do you think about, longevity is easy to measure. We can, measure that one. Get to the wellness.
No, that's a great point, right? So like when I was a tiny person, so I was really focused. I was focused on demography, and there's, in the 1990s, it was essentially a birthright. Like people were living longer. And there was also this idea of compression of morbidity. The idea was that you would, we're all human, so we're eventually going to get frail, but that frailty would happen at the very tail end of your life. And so you'd live most of your life healthy, and then you'd fall off at the very end, right? It looked like there was progress toward that. Sometime in the 2000s, that turned around. The chronic disease crisis that you see now everywhere, what essentially meant that we were not going to have that promise of like compressed morbidity toward the end of your life with longer and longer lives. Economists have like a ton of these measures. I can go into some like geeky details, but it's not worth it. By almost every measure, not just longevity, Americans are not healthier than we were. And the promise for our kids that they will live longer, live healthier lives is gone. And so, I don't want to like put too fine a point on it, but like the huge advances in biomedicine, if they don't translate over to solving that problem, the traditional, almost universal, as you said, Sylvia, support for biomedical research, biomedical innovation, people will start to ask, what are we getting for our money?
And as we think about that wellness, and you've worked on chronic diseases, what are the three in terms of like what would be good measures? Because what gets measured gets done, and how do you think about what are the three things?
Three is tough on this because health is like what is the UN definition or the World Health Organization definition of health? It's like it's not simply the absence of disease, but like it's just it's an insane thing where like
you're not hungry, you're not.
Well, it's like essentially like fulfillment, the ability to lead a fulfilling life, right? That's very difficult to measure because it means different things for different people. But at the very least, we can look at the absence of disease, right? Do we have type 2 diabetes? Have we addressed that? Have we the obesity crisis, the cancer incident, the increasing cancer incidence, the Alzheimer's disease, Parkinson's disease, childhood diseases of kids. So like the autism epidemic, 1 in 31 kids. You can go on and on. These are all things that make the lives of people less fulfilling than they otherwise would be if we had better ways to address them.
Would you put how would you
loneliness
deal
is
with
really
mental
important.
Health? How would you deal with mental health in these measures?
I wrote a paper about loneliness actually with the folks at the AARP because it turns out that lonelier older adults have higher Medicare costs.
Oh yeah.
Loneliness is actually in the UK. I think they have a minister of loneliness of all things. So it's just I don't know what they did during the lockdowns, but whatever. That's another thing.
Maybe we may need to look at the Bhutanese and gross national happiness in terms of what they measure. So let's maybe turn to many folks in this room probably know of you and your work in the COVID epidemic and pandemic, and wanted to start with how you think about COVID itself. It is a virus, and how you think about COVID itself, and then how you think about it and its relationship to public health. Eventually would like to get to a little bit of a dialogue and conversation about preparing for pandemics and how we think we should do that.
Right, so COVID is a viral respiratory disease. Obviously, it has respiratory in the sense of like how it's transmitted. It has other impacts on human health beyond just the respiratory acute phase. Sometimes there's still obviously long COVID. The virus itself, I believe, was the output of essentially lab experiments that the U.S. funded, that the Chinese very sort of irresponsibly invested in. The disease itself, in its early phases, had a mortality rate, infection fatality rate of about somewhere between 2 in 1,000 and 4 in 1,000. I can give you lots of evidence for that. The most important epidemiological fact about it, beyond that mortality rate, is its steep age gradient in mortality, where for every 7 years of age, the mortality risk doubles, right? So the sharpest risk, the greatest mortality risk were for older populations. It's vanishingly low risk of not zero, but vanishingly low risk of acute infection mortality for children, for instance. And then there's this sort of exponential increase in risk with age. The disease it's an RNA virus, so it mutates very, very rapidly. And it's, as a result, it resists having vaccinations that actually can prevent it from spreading or getting infected. The evolution of the virus has a tremendously important role in thinking about like treatments that worked early won't necessarily work late, so on. So there's a lot more we can talk about, but that's how I think about COVID.
And as you think about that and that mortality rate, in the early days, was that the mortality?
Yeah.
The one thing that I think as we start to talk about pandemics is what's known and what's not known, and the importance of, I think we in the health space, all of us, and I speak to Ebola too, we don't communicate enough about, in a pandemic, it is an evolution of knowledge. It's so extremely important to say, here's what we know, here's what we don't know, here's what we kind of know, in terms of this issue, and communicating constantly about because it is an evolution. That's why, the evolution of things that at different points in time. And the public engagement in that. But that brings us to the engagement of this particular issue and public health, which you spent time on and wrote about. And do you want to talk a little bit about that? But this evolution, as you do talk about it, I would love to hear your thinking about the importance of recognizing that in a pandemic, just as the virus is evolving, so is our knowledge, understanding, tools, and the public's perception and understanding.
I think it was like 1994 or 5. I was a third-year med student, I know it's been med school, but like the third year is like the most frightening time for a medical student because you've done 2 years of classwork, and you're going into the clinics meeting patients for the first time. And you put on this white coat, and you're looking at a patient, and the patient looks at you, and they think you know everything because you have the white coat on, but you really don't know any. Oh, Sherry Fink is in the room. She was my medical school colleague, my medical school classmate, so she remembers. And it's absolutely frightening, right? Because you're sitting there in front of the patient, and the patient's like asking you all these questions, and you literally know nothing. You can tell them what the Krebs cycle is, but you can't like answer the question, right? Answer the basic question. So that's what happened to public health collectively. Right? Public health was put in a position where they were asked to answer questions that they did not have the answers to. The big sin you can make as a medical student is you can pretend to knowledge you don't have. Tell the patient things that you don't know to be true. It's fine to say, I don't know. I'll go look, I'll go ask, I'll go do some research for you, I'll get back to you. Right? That's fine, that's good, okay. But it's not okay to say, this is what's happening to you, and you must do X, Y, or Z when you don't know that that's what's happening. You don't have the knowledge. Public health suffered this third-year medical student crisis, and it failed during the pandemic. It pretended knowledge it didn't have, and worse, what it did is it delegitimized honest discussion and debate. And I can tell you that from firsthand experience. It essentially used all the power it had to make sure that people who did not agree with the answers that were being put out, is the virus aerosolized? What is the infection fatality rate? What is the age gradient and mortality risk? How harmful will closing schools be for people? All of that needed to be discussed up front in March of 2020 when the lockdown decision was made, and you could not have that discussion. And it was, I mean, we can point fingers, but like the collectively, that's the root of the crisis we currently face. The honest engagement with the fact that public health failed at its critical moment to have an honest engagement and discussion about the crisis we were facing. It's led to the collapse of public trust in public health. I saw a JAMA article last year, Sylvia, where 70% of patients don't trust their own doctor. And 1 in 4 Americans think that scientists don't have the best interests of Americans at heart. It's a total disaster. We have to figure out a way past that, but that was the problem I had during COVID. It's not that I had all the answers, it's just we needed to have an honest discussion.
And as we think about that going forward and the questions, what are the ways that you can have that kind of, now you're in the jobs now, so you're at NIH, and tomorrow we find out that it's the new H1N1, it's the new COVID, it's we're just starting to see it, we can't tell We don't know the answer. Is it asymptomatically? We don't know. Is it respiratory? Is it aerosolized? Does it go through the air? In terms of, we don't know those answers. And the American people are looking to you, you're head of NIH, to answer those questions. How do you think through what you do? Because one of the things about the time for the dialogue is we kind of got to act because people are dying. How do you weigh that acting and the importance of creating space for dialogue? How do you actually do it? When push comes to shove, people are dying, hospitals are shutting down. In Italy, we saw what happened. In New York, we saw what was happening. How do you balance these two things?
Well, first, you don't panic. That's the rule number one. You certainly don't abet panic. I mean, I think that abetting panics came to be seen in March of 2020 as a virtue. Like, we need to make sure that people are adequately scared. That's a critical mistake in public health. You do not scare the population beyond what you give honest answers. I am very comfortable telling people I don't know. I'm very comfortable with people telling I don't know publicly. I'm very comfortable with saying that I'm wrong when I'm wrong. I think that kind of engagement is going to be, in that kind of crisis, is going to be very, very important. Actually, can we broaden it to like how you prepare for pandemics?
Pandemic preparation.
Because I think we've had the wrong model for pandemic preparation for a very long time. The idea, this goes back, I think, to, let's say 2000, it goes back further than that, but like, let's just start in 2001 in the SARS pandemic, the SARS epidemic, right? That scared the living daylights out of people. You have a naturally occurring virus in bat populations that nobody knew about. We thought coronaviruses were just a common cold. And all of a sudden you got a disease, infection that can like kill it. That had a really high infection fatality rate. Like 10 times more than what COVID had. Even in the early days of March. It luckily didn't seem to spread via aerosols, which is why it didn't cause but it came out of a bat, right? A bat in China. The Chinese hid its spread early on, which made the response a little more difficult. And in 2006, there's the avian flu, right, where H5N1, it doesn't actually infect humans very easily. You have to have a lot of exposure to it in order for it to infect humans, and it's a high death rate if it does infect a human, but there's very little evidence of human-to-human spread, right, which is why we're not all dead. And so, like, you have this like desire to be able to predict what the next pandemic is going to be, but there are like, I don't know, I don't round off error, 1 trillion viruses? I don't know. There's a very large number of viruses out there. And we do not, as humans, have the capacity to go and sort of like a butterfly collect every single last one of them, characterize every one of them. But we chose that as our strategy for predicting and preventing and dealing with the next pandemic. And so what we did is we sent, we had a research program where we send scientists into the remote places of the world, bat caves in China or something, and bring viruses and pathogens they find there into labs, often with inadequate biosecurity or biosafety protocols, make them more transmissible among humans, manipulate them using powerful tools of research, with the idea that if we can tell, if the virus that we pulled out of the bat cave is close in evolutionary space to the viruses, to something that can actually infect humans, well, those of the 1 trillion viruses out there, those are the ones we should prepare for. And then we prepare vaccines or other countermeasures for the virus that has never infected a human. In other words, you prepare vaccines and countermeasures on, essentially in theory, with never testing on humans, and give like contracts to companies to like stockpile them at scale into perpetuity. When the virus actually does make the leap, it will not be the virus that we played with in the lab, because evolution is incredibly creative, right? It will be a very different virus, and the countermeasures we have that we assume will protect us will not protect us, because it's never been tested on humans. That paradigm for pandemic preparedness is a failed paradigm, and especially since there's a risk of a lab leak when you pull the viruses out of the remote places and manipulate them.
So We can, in terms of the preparedness, I want to move on, and because everyone at the top of the hour, we're going to open it up to questions, and want to make sure we're able to do that, because as part of that, your theory of preparedness. So
we haven't even talked about my theory. I'm just saying, I just criticized the old theory, but
yes. In terms of the inclusion of preparedness, in terms of our ability to know and understand when something is happening somewhere. So surveillance, capabilities of surveillance, capabilities of developing testing capability quite quickly. In terms of some of the things that one could do, that we do. That was a portion of the strategy of preparedness, but another portion are some of those other elements, and maybe we'll come to that through some of the questions. But before we open up to questions, I wanted to try and get two more in. And at the end of the week last week, we heard a lot in the news about vaccinations, particularly Hep B. And at HHS, you kind of have a troika of FDA, Food and Drug Administration, NIH, National Institutes of Health, and CDC, the Center for Disease Control. And those three working together is like quite an important thing to outcomes for both public health and individual health, for that matter. And so as we think about that, at HHS, they usually are working together, and wanted to kind of understand how is that working now in terms of the relationships, and how were you all able to engage or not in those issues, the vaccination issues?
I mean, there's quite good relations between me and Marty McCary and Mehmet Oz and Bobby. I mean, so in that sense, that at the top level, there's a lot of like sort of desire to coordinate. But of course, the NIH, the FDA, and the CDC have very, very different roles, right? So the NIH is a slow burn. Like, we invest in research, and Lord willing, 3, 5, 10 years from now, there'll be some huge advance. Someone will win a Nobel Prize, and Americans will be healthier, right? That's the NIH. The FDA, they're responsible for deciding whether to approve the vaccines, for instance, for use, if there's standards for that, and they're also responsible for post-market surveillance, if there's safety signals to identify them and say that. And then CDC is the public health agency, like, primarily. So they make recommendations about well, should you vaccinate your kids? When should you vaccinate your kids? And so on. And those are three very, very distinct roles. We can talk about this, but like the science, medicine, and public health, I think have very different. I mean, while we're aligned in the sense of like the ultimate goal, which is better health for people, they have very different standards and norms, and are actually it's in tension with each other to some degree, right? Just take the Hep B question, right? So the Hep B. The issue there was, the primary issue, the point of the arrow there, as you say, was should parents and doctors together decide when to give a child a Hep B vaccination, right? The whole controversy was over shared decision making on timing, right? And so that is. You can ask about the FDA, the NIH, and the CDC as like decision makers that can help contribute to this discussion. But fundamentally, that is a question for the public at large. And this has to do with like the role of public health versus the role of medicine versus the role of science, right? So let's just take public health and medicine. When you see a doctor, do you want that doctor to represent your interests, or do you want that doctor to represent public interests? When you're sick and you go to a doctor, whose interest do you want that doctor to represent? If there's a tension between the public interest and the interest of the patient, who should the doctor represent? So the real issue, the real substantive issue at stake with that Hep B decision was that, like, should you have shared decision making between the doctor and the patient in deciding the timing of the vaccines, or should you have public health considerations at play? And especially this is in light of like a vast collapse in the trust that Americans have in doctors, and in vaccines right now, in ways that are, as a doctor, quite distressing. So I think that's the real issue that really the press went crazy, but we sort of didn't get to have a real discussion yet about the fundamental issue at stake.
However, I want to go back to your thesis, your dissertation. I want to take us back to your dissertation.
Okay.
Where markets didn't work.
Yeah.
We learned from your dissertation that markets didn't work and surgeons were paid disproportionately. And now my question actually applies to science and the individual's interest. And let's just use Alexis de Tocqueville, self-interest well understood. So if I accept the premise of part of this conversation, which is that we want the doctor representing the individual, and or to what extent? That was, I think, let me frame the question that way. In a world where we know the facts. We know the facts around Hep B and what happened before and after in terms of people's ability to make that decision, both at that time, 29 hours of labor. I'm not sure how cogent I was at that point in time, in terms of making these decisions and that sort of thing, an ability to do that in terms of protecting the child. And so just in terms of the reason that NIH is connected is because the science and the research that gives us information about when these things are decisions that we see. If we move the decisions to one place, what results we get from a measurable place. And so, just as that's the scientific connection.
Yeah. So on that, it's still to me, it's an open question, right? So like a lot of other countries do it very differently, right? So they don't recommend the birth dose of Hep B. They recommend the dose at 2 months for patients who are Hep B for moms who are Hep B negative. They recommend 2 months. Right, and so, a lot of countries do it differently. I think it's a legitimate, interesting scientific question. What that impact? That's the kind of thing that science ought to be interested in. I'm quite interested in that. But it's not an open. It's not a closed question in my view. Right. So, actually, this relates to the tension between science and public health. Right. The ethical norm in public health is unanimity. Right. If I go around as NIH director saying that smoking is not that bad for you, might even be good for you, which is not, it's terrible for you, don't smoke.
We're clear on this?
Yes.
So no one walks out of this room. I want to be clear that we said the other part.
But I will have committed a sin, right? I will have essentially violated sort of my obligation as someone in a position of authority and power in science in public health to like encourage people to do something that I know is really the scientific evidence is bad for them. There's this unanimity of messaging. Unanimity of messaging is an ethical norm in public health. In science, it's the opposite. As a scientist, you must question whether established knowledge is true or false, is true. It is, you're not doing that, you're not a good scientist, right? You are always probing, and very few questions are off limits. Very few questions are off limits. And so you have a clash of norms that you saw play out during the pandemic, where dissident scientists were subject to devastating takedowns, were essentially silenced, marginalized, delegitimized because they were asking scientific questions about the basis for the kinds of advice that was given during the pandemic. I mean, this is a fundamental tension, right? Both between medicine and public health and science and public health, right? So.
We were going to discuss this tension about public health, individual health, and get into this, but we don't have
Sorry
time
for jumping you.
No, I think we don't have time, but one of the things I would just add is you can't keep them separated because you also have to add economics. And so let's just do who's going to pay for mammograms and when. That's one of the easiest examples. And to have a health system, though, and that's why when you're sitting in the seat I sat in, one has to think about it from a systemic approach.
I thought my job was hard. That is an impossible job. I have no idea how you or Bobby or those others do it. It's just.
It is the.
I just have to do science. I mean, that's
No, I mean it is, but it is the when one thinks about all this, it is that ability to bring all those elements. And I see one of my colleagues from HHS here. Richard Frank, economist, health economist. But it is bringing all of those pieces together and making decisions and trading off. trading off that individual advice of the doctor, trading off the insurance companies and payers, companies, individuals, the federal government, your tax dollars, ability to create a system that works, and you got to bring it all together. And that's where one's willingness to gather the different pieces and then make judgments becomes so important. We were going to go down that path. We talked a little bit before, but we don't have time. We figured out we could have we could go for days. But we're going to open it up instead in the room. And if you wouldn't mind just introducing yourself before you ask your question, that would be terrific. We're going to start in the room, and then I'm going to make sure I turn and see if we have anything online. Let's start right here, and then we'll go here and here.
Thank you. Earl Carr, representing CJPA Global Advisors. Thank you for a fascinating discussion. I want to go back to your question about being honest with the public about not knowing. In the middle of a health crisis, if you were to tell the public, we don't know, would that not ostensibly cause more of a health crisis because people are counting on you and experts and scientists to understand and diagnose what the problem is? I mean, we have it in hindsight. Hindsight's always 20/20, but I'm just wondering if that would have caused even more of an uproar if you were to be honest with the public.
Earl, I mean, thank you for that question, but I think the answer is no. I think the public is much more sophisticated than we think. If I say I don't know and I follow it up with, here's what we're doing to find out, I think the public will respect that much more than, I know this is true, trust me, and then ex post it's not true. Right, I think that is a recipe for disaster. That's the recipe we followed during the pandemic. And I think it's not just the pandemic, right? On question after, why are autism rates rising? Like 1 in 31 now, and 1 in 10, was it 10,000? I don't know, some numbers much smaller before. I have seen 25 different theories for why, including new diagnosis criteria, the economic incentives to have an autism diagnosis, to more biological questions. And as a scientist, I don't know the answer. And when I've been asked, I was asked this by the Senate, like and when I was testifying in front of the Senate, and the honest answer is I don't know. And what I want to do about it is I want to support research with a broad range of hypotheses so that we can get an answer. Right? There are families with severely autistic kids that are suffering that deserve better answers for why their kids are suffering and how we can alleviate that suffering and how we can potentially prevent that suffering for future families. I think if we talk to the public that way, just honestly, the same way we talk to each other when we're in whatever faculty lounge or something, I think people will respond much more to that honesty with trust than they would if you pretend to knowledge you don't have.
How do you think about the next part of that, which is, I don't know. I don't know if Tylenol, I don't know, but I'm going to put a warning.
Okay, I don't know whether sushi eating during pregnancy is bad for kids or bad for, I don't know. I mean, I've looked at that. My wife made me look at the evidence. She had 3 kids, so yeah. So actually, she looked at the evidence herself, but that's another.
And she is a physician.
She's a doctor, yeah. So she's just, we have fun.
We would trust as my.
You should trust my wife more than actually, honestly.
That was the point I was making.
Yes. I mean, I'll tell you that, and she'll tell you that, so it's fine. So, but yeah. So I think so like there's a lot especially around pregnancy, about exposures we don't know, because it is very difficult, almost impossible, to run randomized trials with pregnant women as the subjects for reasons you can completely understand, right? And so that means we're left with this evidence vacuum. And so then the public health space is very, very risk averse, and they say, okay, well, there's this idea in Judaism of putting a ring around the Torah, where you're like, you don't want to violate God's law, so you start not doing lots of things that not explicitly part of God's law, right? So that's what public health is like. Let's put a ring around the uncertainty. So you don't eat sushi. There was a health economist colleague of mine, Emily Oster, who wrote a book about light to moderate drinking during pregnancy. and she got all kinds of grief from like all the pediatricians. She pointed out there's not very good evidence on this. That's where we are, right? So in light of that fact that we don't have very good evidence, I believe very fundamentally in shared decision making. I tell you, here's what we know, here's what we don't know. At least as far as I'm concerned, I might be wrong. You guys can disagree with me about how you evaluate the evidence, but like I'll tell you my honest assessment of the evidence, and then say, so like for instance, the Tylenol decision essentially was that there is some evidence. In fact, there's a 2021 consensus report from a whole bunch of scientists around the world that there was a correlation in large studies, in large epidemiological studies between Tylenol use during pregnancy and subsequent autism diagnoses. There was a bunch of controversy over that, because if you look at the epidemiological studies, large-scale epidemiological studies, you find the correlation. But then when you do sibling studies, so discordant sibling studies, where the same mom, one kid was exposed to Tylenol during pregnancy, one kid wasn't, you tend to find no correlation. There are methodological issues I could go deep into with the sibling studies, but it's not worth going into it. There's uncertainty. There's not randomized evidence where it would clear up that uncertainty. So why not treat Tylenol the way we treat sushi and light alcohol drinking?
Well, there's also the word correlation.
Same thing with sushi eating, same thing with
Right.
light
But
alcohol
that's-
use.
Yes. But
Yes.
across the board, the question of correlation, you know.
I mean, the big difference between sushi eating and light alcohol use is you have a pharmaceutical interest company that has a very, very strong interest in not finding that. There was a company that J&J had Tylenol. They sold the Tylenol interest to Kenvue when the first report started coming out about the potential link between Tylenol and autism, right? That was in 2021. So this is a matter of public health. I didn't get to make that decision about how public it's other agencies. I'm going to fund research on this. That's the job of the NIH.
Let's go to the next question.
Hi, thanks for holding this session. I'm Gigi Gromval. I'm a professor at Johns Hopkins Bloomberg School of Public Health. I have a question about mRNA vaccines. You stated that they failed to earn the public trust and used that to justify deprioritizing them and investing instead in an antiquated influenza vaccine technology instead. What scientific rationale supports that decision, and what, especially given the evidence that mRNA vaccines are safe and effective and have a lot of future potential?
So Gigi, I think you have a number of assertions you make that a lot of scientists would disagree with. So first of all, on the platform, the loss of public trust in the platform, the CDC's recommendation was that all 6-month-olds in this country be vaccinated with the mRNA vaccine for COVID. And something like 10% of parents actually followed that advice. The CDC's advice was that essentially like more or less universal repeat booster vaccinations using the mRNA platform. 30% of the American population actually followed that advice. We've invested billions of dollars in a platform that the public health authority is saying you should use at scale for COVID vaccines, and most of the American public is not using it. If we invest in a platform, let's say you're right, and I don't agree with you that you're right, but like let's say you're right about the scientific evidence about the efficacy and safety and efficacy of the COVID vaccines. The fact is that the public does not actually believe you, doesn't believe us. So why should we invest in a platform that does? Now, as a NIH, we have a lot of investments in mRNA technology, for instance, in cancer vaccines, I think are very promising. We're still investing in those. We're going to continue to invest in those. I don't think the public trust has been lost. But the assertion, for instance, that the COVID vaccine prevents you from getting COVID or prevents you from spreading COVID, which turned out to be false. Then on top of that, all of these like vaccine mandates related to the COVID vaccine, I can completely understand why there's loss of public trust in the COVID vaccines. Actually, more broadly in vaccines, which I have much more trouble with. So yeah, I think the issue here is one of like where should we put our investments if we want to improve public health. The mRNA vaccines, in that sense, have not mRNA COVID vaccines have failed to adequately protect us. As far as the flu vaccine, the BPL technology is actually quite promising. I know scientists who fundamentally disagree with you about what you just said, antiquated. It seems like a safe technology. It's certainly worth investing in the science for it. We have major flu problems in this country. We need better flu vaccines.
But with regard to the numbers, you said only 30% of people were taking the mRNA vaccine.
COVID vaccine, yeah.
The COVID vaccine, I'm sorry.
Yeah.
That's the total for COVID?
Yeah.
Because the question becomes, is it that they don't believe in COVID vaccines or they don't believe in the mRNA vaccine in terms of the public's perception of things? And I would also just say, like, there are many things that, as we know from a public health perspective, like, okay, everybody who's over 50, have you gotten your colonoscopy? Like, in terms of like...
It's not 30% compliance with that.
But my point, exactly.
It's not, it's much higher than that, right? So,
Well,
I mean, we've been pretty successful.
But we have, it takes a
until
lot
the
of time.
lockdowns.
It takes a lot of time to get people to understand, like, how many of our kids now get, the right vaccines when they turn 12 to prevent, certain types of cancers. And so I just, the question of basing, I'm just wondering about basing things on where we think the public is versus what we actually believe is the effectiveness.
Well, let's just see
It's
what
an
Sylvia's clear.
argument.
So,
That's
Sylvia, you cannot ignore the public perceptions of the efficacy and safety of products in making public health decisions where you're essentially requiring or essentially recommending the public at scale to take it, right? And especially if we're making billions of dollars investment in this of taxpayer money in it, you have to take into account where the public is. Now, if you want the public to change where they are in their perceptions of it, you have to work honestly with the public to do that, right? So you have to tell them, you have to make the case to the public in ways that are meaningful to the public. You can't just assert, because I'm a scientist, I know, and that's good enough. I mean, that was the tact we took during the pandemic, and it didn't work, right? It's led us to this place of loss of trust.
But smoking, we didn't encourage people to smoke, while we were getting them to understand that it was a bad idea. The public.
No, we kind of did actually, but that's another thing. I mean, there were like ads on TV. I mean, it took a long time, right?
But the public health, in terms of, let's keep moving. Let's keep moving.
Mr. Director, thank you so much for coming today. My name is Mark Vlasic. I split time between teaching at Georgetown. I'm a TV producer and film producer in Hollywood. But early in my life, I started in the Army and also worked for Secretary of Defense Robert Gates. And it's from that chapter I had some exposure to the challenges of mental health, PTSD issues from our soldiers and Marines, what have you. And of course, the fact that we've lost more people to suicide than from those combat situations. I'd love to hear your thoughts, anything you'd like to share on breakthrough treatments for PTSD. Where is that research going, and are you interested in advancing that?
I'm absolutely interested in advancing it. This is not my area, so I'm going to be a little careful about like specific. I mean, I can tell you what I think, but it's worth what you pay for it. I don't have to be paid for this, but I do think that's a fundamentally important area, of course, for soldiers, but for more broadly, the paradigms we have been using for managing depression, anxiety, PTSD, all of these. I mean, I get emails from so many people telling me they're not working. And I hear from lots and lots of scientists with different ideas, very different ideas than the standard, take an SSRI and go home. And I think we owe those patients an answer and a broader range of thinking about this. I'm in the middle of selecting a new NIMH director. And one of my criteria for selecting that person will be, first, an absolute commitment to rigor in science, but also a broad range of, like an open-mindedness to this. I mean, I've had people tell me that psilocybin is the way. I have no idea. I don't know. I mean, I looked at the literature and I can't tell if it's the way or not. At the same time, I think a rigorous evaluation of it is something we owe the public, right? Yeah.
I think we have a question online. I'm going to turn to Sophia for that, and then we'll come to this table right here and then come back up here.
We'll take our next question from Robert Klitzman. Please accept the unmute now prompt. Yes, I'm Robert Klitzman. I'm a professor in the medical school and the School of Public Health at Columbia University. So thank you very much for speaking with us today. You mentioned shared decision making as being important in vaccines and vaccine policy. But one important aspect of taking a vaccine or having a child take a vaccine is that one is helping not only one's own health, but the health of the community, the health of family, the health of others. And given that a lot of the public has relatively low scientific literacy, 1/4 of people don't understand, don't know that the Earth goes around the sun, for instance. Can we really leave it up to the public to make decisions about whether to get vaccines or not? Won't that be sort of leading to problems for public health rather than helping it?
Thank you for that question. I guess we live in a republic where the premise is that people are in a sense sovereign, treating people as if they don't know or understand or somehow like are less is a recipe for making sure that people don't trust you. On the question of vaccines specifically, well, you know, it's actually a scientific question, like what the transmission blocking properties of a vaccine. I think MMR is fantastic at transmission blocking. Like you take it and you're not going to get you know, measles like ever. It's a fantastic vaccine for that. But there are other vaccines where there's much less evidence of transmission blocking. In health economics or economics, we have this idea of externalities, right? So the question of what are the positive externalities generated by vaccines is an empirical question. It's not always the case that every single vaccine automatically, just because you call it a vaccine, blocks transmission. We found out during COVID that's obviously not true for the COVID vaccines. So, you know, I think, and then the question is, once you have a positive externality, you've established a positive externality, should you ignore the will or desires or thoughts of people and compel them to take something they don't want to take because they don't trust you? I mean, you know, we can have that debate. I'm pretty sure I know which way it'll go. So, and I think the right approach, you can look at with Scandinavian countries. They do not mandate vaccines. The UK doesn't mandate the childhood vaccines, and yet they have, in the Scandinavian countries, more than 95% uptake of the childhood vaccines. It's because they have a public health infrastructure and structure that the public trusts. They don't believe that they're trying to snow them over. They don't believe they're trying to force them to do things. Establishing that trust is the essential aspect of public health. And if you think about people as somehow ignorant or less, or like half the population is a basket of deplorables or whatever, you are guaranteed not to earn their trust.
Linda.
Thank you so much for meeting with. Thank you so much for meeting with us, Linda Laurie. Purpose of this, former OSTP, White House, former DOD. Being as we're at the Council on Foreign Relations, wanted to take us internationally, particularly to China. And there's been a lot of examples. We can go through them, but I'm sure you're familiar, and probably other people in the room are, of NIH and other US government research that forms the basis for Chinese AI, computer vision, and other surveillance-enabling technologies that pose a risk to human rights and to national security in general, particularly through the MILSIV fusion policy. Can you share what NIH is doing to implement the National Security Presidential Memorandum 33 on research security, which was a Trump 1 policy that was implemented and enhanced by the Biden administration, and as well as ensuring that NIH-funded research doesn't find its way into Chinese research institutions and companies? Thank you.
Okay, thanks for that question. I don't want to get too deep into like the specifics, because there's still a lot of ongoing discussions in the administration and inside the NIH about exactly how we're going to do this. I think first the NIH has to be part of a broader policy. It can't just be us acting alone on China. But let me just let me just broaden it out for the discussion, right? And let me start with just the first fact, which is, and just I think buttresses what the premise of your question. The United States has invested a tremendous amount of money in the biomedical research infrastructure of China. Almost every single biomedical scientist of note in China trained in the United States and has, and in some way or other, has received support from the NIH or other scientific institutions. That's fact one. Fact two, the Chinese biomedical infrastructure, research infrastructure, is not inferior to ours. It might even be better than ours. It's fact 2, right? And fact 3, there are real national security threats given those 2 facts. So for instance, there are supply chains for essential medicines that run through China that can get turned off in the context of hostilities or tension or whatever. So these are like, I mean, it's like a Sputnik moment in some sense. Okay, so what are the 2? I see 2 possible paths forward, and I don't know where we're gonna end up. Because I do also think that we have a scientific interest in collaborating with scientists around the world. Putting my naive hat on as a scientist, it's good for science to talk with lots and lots of scientists, to talk to lots and lots of people, lots of ideas. And international scientific exchange of ideas is like the hallmark of, like, you know, I grew up in a town with a lot of hippies. They were all into, like, you know, you like eat carob chips and have scientists talk to each other to make peace with the Soviet Union or something, right? So you have 2 possibilities I see, and I don't know which way we're going to end up. One is a divorce with China, a scientific divorce with China, kind of like what happened in 1948 with the USSR and the US. I think that would be a disaster in many, 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 many ways. I would love to see ways to avoid that. On the other hand, we have a regulatory structure that better protects American intellectual property rights, that better establishes domestic supply chains, and reduces the reliance on Chinese, you know, biomedicine for American needs. That's the best outcome. I think the only outcome. The other outcome is we just keep doing what we're doing. That's not gonna work. I mean, it's not in American interest. I'm actually open to hearing how to do this. We're actively talking inside the administration about these matters, and I'm thinking about it. So this is a Council of Foreign Relations, right? So you guys have more expertise than I do about this topic.
Thank you. I think we have time for one more up front here, and then we will wrap up.
Good morning. Thank you. Good morning. Thank you so much for the opportunity to be here this morning. My name is Ruby Kakonge, Uganda's ambassador to the U.S. One of the strongest relationships we have with the U.S. is in public health. How would you guide that we improve on this relationship, especially in communication and post-COVID?
Yeah, thank you for that. I mean, I think a lot of the countries in the world were poorly served by the WHO, I think, during COVID. A lot of bad advice, especially to poorer countries, that devastated you know, the lives of so many poor people around the world. The administration is pulling out of the WHO, but we don't just want it. We're not doing that in order to disengage from the world. We actively want to engage more constructively with the world on matters of public health. And so what the discussions are going on now is for how to reach out to countries, to collaborate with countries that in ways that can actually advance the health interests of those countries, and collaborate with the U.S. so that we can, you know, help each other on our health decisions, right? So a lot of the fights have been over infectious disease. We talked about that, but in many poor countries, infectious disease is not the primary, is not the only health threat. You know, there are chronic diseases that are really important in so many countries that are ignored. There are existing health problems and infrastructure that's not just focused on infectious disease. Now, of course, infectious disease is still a problem, but that's so I think it's a work in progress. But the desire is there to collaborate together in a more cooperative way on public health. What I saw during the pandemic was essentially global public health spread advice to countries. I talked to some folks I saw firsthand in Sri Lanka, because I was in contact with a lot of them. Advice that was guaranteed to harm the well-being of the poor in ways that are, I mean, there's still, you know, it just breaks my heart to think about. And it's because they're essentially the Western panic over COVID. The advice was to elevate COVID in a country where there's a very relatively small number of older people, and elevate that as the primary health concern, when in fact there's so many other health concerns that are more important in the context of countries that are young, that have a younger population. I mean, it's true in Africa, all across Africa. This was the case. I don't know again what the ultimate thing will be, but the desire of the United States is to help have a more collaborative relationship on public health with countries around the world in ways that better serve their interest and ours. And the WHO has failed at that.
Thank you. I want to thank all of those who joined us online today, as well as all of you all in the room. And I'd like to ask you all to thank our guest today, Dr. Jay Bhattacharya.